Okay. So a very good morning to everyone present here. We at Fine Roots of Dentinos are delighted to be back after a really long time with another insightful session for our community of dental students and professionals. Today's session is on a topic that every dentist must understand deeply: management of a cracked tooth. Early recognition of a cracked tooth syndrome is going to make a difference between that is saving the tooth or either losing it. And that's exactly why we have an amazing speaker here with us today to help us navigate that problem. For this session, we are truly privileged to have with us Dr. Urvashi Tanwar ma'am, who is an accomplished MDS endodontist and a restorative dentist. She is a proud owner of Asharya Dental Care in Delhi. She has secured the second rank in Karnataka during her PGs and has won several rewards for her publications in scientific journals as well. So today, Dr. Tanwar is also going to share with us the crack the code. That's the presentation that she has in front of us today. She is going to tell us exactly what we need to do to save the tooth. Her passion for excellence and her ability to simplify these complex procedures is going to be the perfect start to our webinar today. So I'm going to present to you a very, very renowned speaker, Dr. Urvashi ma'am. Please join me in welcoming her today. Over to you, ma'am.
Thank you so much, Dr. Japleen, for the wonderful introduction. I hope I'm audible and that my audio is clear enough.
Yes,
In,
ma'am.
in case there are any issues, just let me know, and I will try to figure it out. So let's go ahead and start this webinar without further ado. A patient once told me that, doctor, every time I sip coffee or bite bread, I feel a sudden lightning pain. The tooth looked fine from the outside, no cavity, no decay, but inside it was silently cracking. Cracked teeth are now one of the top causes of tooth loss in adults and often mistaken for sensitivity until it's too late. Teeth cracks are now so common that the prevalence rates are almost up to a 70%, depending on the type of tooth and location. The diagnosis and treatment of these cracked teeth are often a significant challenge for the practitioner, and the outcomes can be consequential with the need for major restoration of fillings, root canal therapy, or even in some cases, leading up to extraction. As a result, finding the best treatment option for cracked teeth is a priority, and I'm sure most of you are confused in this regard as to how to treat the cracked tooth or how to even diagnose one. So, today in Crack the Code, we'll uncover how to spot these hidden fractures early and how modern dentistry helps us save them before they shatter. So, for those who don't know me, I'm Dr. Urvashi, a restorative dentist and endodontist by training, and a passionate advocate of minimally invasive dentistry. I run my own practice, Asharya Dental Care in Delhi, where we focus on predictable, long lasting, and aesthetic dentistry with a special love for rubber dam isolation and bonded restorations. Teaching and sharing has always been my happy space, so I'm excited to be here with all of you today. Okay, so before we dive in, here's a roadmap for today's session. We'll begin with the definition of cracked teeth to set the foundation, and then we'll move on to classification, understanding the different types of cracks we encounter. Then we'll look at etiology of why these cracks develop in the first place. And from there, we'll explore the pathology and consequences of what really happens inside the tooth when the cracks progress. We'll also cover diagnosis, the tools, and the clinical signs that help us detect them early. And finally, we'll discuss therapeutic strategies and the best ways to save, manage, and preserve these teeth. So by the end of the session, basically, you'll not only recognize cracked teeth better, but you'll also feel confident about choosing the right treatment plan. Let's move on to the definition first. The first report where the symptoms of incomplete fracture of posterior teeth involving cusps was detailed and mentioned was by Gibbs in actually 1954, and he termed this condition as cuspal fracture odontologia. This definition was later modified, and today we have the current definition given by AAE that defines amelodentinal coronal fractures as incomplete fractures without visible separation or mobility of the fragments that initiate at the coronal level and extend apically, most often in a mesiodistal direction. This please mind, differs from complete longitudinal dental fractures where two fragments are mobile and separable. At this point, I want to emphasize on this that the cracked tooth syndrome, the use of the term syndrome is actually misleading because a syndrome is defined as a number of symptoms occurring together, characterizing a specific disease. Clearly, a crack in a tooth is not a disease, and therefore the term syndrome is inappropriate. So, as an example, the so called cracked tooth syndrome is often confused with vertical root fractures when it is not. So, that is why a crack tooth syndrome, the word syndrome should be avoided, and we should just use cracked teeth or just cracks in general for these teeth. Coming to the AA classification, the five most commonly used classifications of cracked teeth given by them. The first is the Kray's line, which is asymptomatic. And then next is the fractured cusp, which is, you have mild pain mostly during biting and in the cold, but with a better prognosis. The third is the cracked tooth, where you have severe pain during biting, depending on the depth and the extent of the fracture. The fourth one is a split tooth where you have pain during chewing. And the last is a vertical root fracture where you have severe pain and it usually has a poor prognosis. I want to emphasize gently on the symptoms of cracked tooth over here, which includes spontaneous pain, pain on biting, irritation with cold, especially pain on having sweet food is very, very characteristic of a cracked tooth. The bite pain gets worse when the bite force increases, and in such situations, patients often complain and often seek medical attention. So, this is when the patient is coming to you. Mind you, in today's webinar, we will be dealing only with the cracked tooth and we'll not be discussing other variants and how to manage them at all. Okay. So, the predisposing factors for a cracked tooth are the factors that actually increase the force acting on the teeth or those that weaken the resistance of the tooth to the chewing force. Okay. So, we have like a various variety of factors that are involved. They can be broadly classified into non iatrogenic factors and factors that are originating from the tooth. If we look at non-iatrogenic factors, you can include aging, oral habits, or the dental structure itself. And I'll talk about it soon in a bit detail. Like over the age of 40, as the age increases, we all know that the degree of fatigue of the tooth increases, the hard tissue will become fragile, and the elasticity of the dentine is also lost. So, in such cases, when the force is imposed on the tooth, it exceeds the limit of dentinal elasticity, the teeth crack. Okay, and that is what is mentioned here. If you have an increasing number of restored teeth, if you have increased thermal cycling, eating habits, long-term unilateral chewing, especially when you have a missing tooth or missing number of missing teeth on one side, patients tend to chew on the opposite side, and that increases the load on the tooth, sleep bruxism, precocious occlusion, and as well as structural defects in the tooth or cuspal inclination. The normal bite force in humans, as we all know, ranges between 3 to 30 kgs, and hence, when teeth are subjected to forces beyond this range, such as chewing hard objects, the probability of the tooth structure getting damaged increases. It's but obvious. Coming to odontoiatrogenic factors, we have head and neck radiotherapy, HNRT, and it impacts the tooth structure. On one hand, it directly affects the tooth structure where it changes the protein composition that forms the cleavage plane of the tooth, as well as affecting the production of porous enamel at the dental cervix. Because of the radiotherapy, you'll also have a decrease in the saliva flow, which will in turn cause the tooth enamel to become very brittle in a dry environment. And that, of course, will lead to decrease in the fracture toughness of the tooth. The organic matter in the DJ will get reduced due to dehydration, or the anchorage between the dentine and enamel gets reduced. In such cases, even normal bite forces is going to end up cracking the tooth. This altered characteristics of the DJ also changes the distribution of mechanical stress, and it increases the probability of the enamel Kray's lines extending onto the dentine surface as well. In addition to these salivary alterations, the daily diet of the patients is also changing who are undergoing this head and neck radiation therapy, and they tend to have low oral pH resulting again in tooth demineralization. Coming to other factors, if you have, especially canal therapy, the contact between the instrument and the canal wall, if you use high concentration of sodium hypochlorite, excessive widening of the root canal would lead to increased stress concentration and, fractures in the root as well. Excessive restorative procedures leading to excessive removal of the tooth tissue, or when you have these metallic materials, especially compression stresses or the contraction stresses due to the composite shrinking or the amalgam extending, all these metallic materials, putting stress on the tooth. And that's where you see whenever you have all these amalgam restorations, and I'll show you a few in the coming slides, you always have some sort of cracks developing around these restorations. You must have seen it, it's very common. This is in fact called peripheral rim fracture, induced due to the expansion stresses of the metallic material, the nature of the amalgam. And in turn, these peripheral rim fractures end up causing occlusal effect caries, which means these cracks carry and develop biofilms which carry all the bacterial organisms all the way down and end up causing a lot of decay. So, decay due to these cracks is called occlusal effect caries. So, these are some of the causes that basically end up cracking the tooth. Some are related to the tooth, some are caused by us, some are just, due to the structure of the tooth. Now let's come to crack pathology. Chai et al. Described areas of enamel called tufts located at the DJ, which improve the mechanical properties of the enamel by allowing it to bear stresses, right? So basically, what I am going to discuss now are structures in the tooth itself, which is the enamel, then you encounter the DJ, and then you encounter the dentine. So, how the tooth itself has developed certain mechanisms, in itself to resist these cracks, which is why I'm talking about these tufts. They are located at the DJ. Okay, they are actually supposed to resist cracks, but paradoxically they also act as weak areas because they are actually intrinsic defects of the microstructure that serve as starting point for the development of cracks. Okay, so in the tooth tissue we have both structures that are trying to inhibit crack propagation, but at the same time, because of the structure that they end up propagating more cracks. Okay, so tufts are actually hypomineralized areas. We all learned it in dental anatomy and histology in our first year. They are high protein concentrations and they're located at the level of DJ. Now, natural enamel cracks extend from the DJ to the occlusal surface, but some are stopped along their path through the enamel. So basically, let's look at mechanisms to increase resistance to crack growth in enamel. This is what is going on in the enamel. The deviation that takes place in the transition region between the internal and external enamel. So basically, in the external enamel, the enamel prisms are relatively straight, and the cracks extend along these prisms. While in the internal enamel, the cracks meet oblique prisms, which cause their deviation. The next is microcracking, which prevents the propagation of cracks in the internal enamel. Now, microcracking occurs in front of a growing crack and it slows down the main crack by reducing the intensity of the local stress by dividing the crack. And the last one is crack bridging. This prevents the propagation of cracks in the internal enamel. How? These bridges, basically induced by the organic matrix within the internal enamel, promote the closure of cracks thanks to the maintenance of the protein frame, and they stop crack growth. So these mechanisms seem to exist only in the internal enamel, particularly in the zone of decussation, and contribute to making the enamel an extremely tenacious tissue against the propagation of cracks. So as I told you in the classification when you saw earlier, Kray's lines existing only in enamel are asymptomatic. They do not need any sort of treatment. They are completely harmless because enamel is doing all these things in resisting crack growth and propagation. But when you come to dentine, it has been found that the crack, no, we're looking at DJ now. So it has been found that the crack arrest mechanism only appears if the cracks approach the DJ on the enamel side, right? As I told you, enamel is a very tenacious structure. So the enamel acts as a compression dome. The enamel compression loads are transferred via the DJ to the dentine, and in this transfer, a stress concentration occurs at the DJ as it converts the enamel vertical load into a horizontal load in the dentine. Now, these are some of the characteristics of the DJ, which is a bit of lower mineralization compared to your enamel, and it has more higher collagen content, which again prevents stress concentration. The design itself, the scalloped, the microscallop structure of the DEJ, allows optimal cohesion between enamel and dentine, and it forms a complex which is capable of plastic deformation, which means it is capable of some movement. Crack arrest is explained by a differential modulus of elasticity between enamel and dentine. But when you come to dentine itself, the resistance of cracking decreases from the DJ to the pulp because of the increase in the dentinal tubules and the decrease of hydroxyapatite crystals. And this allows for easier crack propagation, which is why whenever you have cracks in the dentine, they need to be removed because they will propagate and they will propagate in a very fast manner. You have the mantle dentine, which is the dentine right below the DJ, and it participates in stopping the cracks due to its tenacity, which is because its mineral content is slightly lower and because it contains a few dentinal tubules. So till just below the dentine, it is capable of, stopping to some extent the propagation of a crack. But then beyond that, it continues very fast because of the nature of the dentine structure itself. It is important to note that not all cracks will lead to pulp and periradicular diseases. These problems will only occur if a sufficient number of bacteria are present in the crack and if the particular bacteria are virulent enough to cause pulp and periradicular diseases. Further, factors are the state of the health of the particular pulp at the time of bacterial invasion and whether the pulp can resist the invasion of bacteria or the irritation created by the endotoxins. So this is why it is so important to understand what the biological consequences of a crack are. They are a potential pathway of entry of bacteria into the tooth, but we cannot say for sure that they will be causing pulpar and periradicular diseases, okay? A crack on the marginal ridge leads to significant weakening, and the loss of a marginal ridge leads to a reduction of 46% of the tooth strength and 63% in the event of the loss of two marginal ridges. Lateral chewing forces as well as cavity preparations create internal shear and tensile stresses that can lead to complete or incomplete fracture of the root. If you have a crack growth in the direction of the pulp, it may require endodontic treatment and therefore it leads to significant weakening of the tooth. And in extreme cases, as we all know, a crack can lead to a longitudinal fracture and subsequently extraction. Coming to diagnosis, during earlier stages of the cracked tooth, when the symptoms and the signs are frequently blurred, it is generally very difficult for us dentists to diagnose these cracked teeth. Dentists must arrive at a clear diagnosis as much as possible, and currently, there are multiple techniques that include the following. So, coming to clinical examination, you have a combination of percussion, point load. Point load is when we particularly put stress on a single cusp or two cusps or one particular tooth to understand if this is the offending tooth or not. Cold simulation test to find the sick tooth or use a special plastic bite block. I will show you in the coming slides. You can also have transillumination where you are placing a light beam perpendicular to the supposed crack plane. So if the tooth is deeply cracked, the light is blocked and only part of the tooth is illuminated. Hypersensitivity to cold is the most common symptom of dental cracking. And according to a study done by Hilton, 81% of patients with a dental crack experience pain in response to cold. So you'll be doing a clinical examination with the help of a tooth sleuth, which looks like this. If you don't have this, you can also take a cement spatula, wrap it in cotton, and place it only on the cusp that you're trying to check for that if it's a cracked tooth or not. Next, you'll come at illumination, trans illumination. I'll show you a few pictures after that. And pulse sensitivity, mostly the patient will come to you saying that they have sensitivity to cold, and you can do the same with the help of a cold test. Okay. You can also use methylene blue dyes, the methylene blue dye staining. It helps in the visual detection of coronal cracks, if any. And this is due to the aggregation tendency of the dye. The use of the dye may hide cracks also, but it will lead to a subtle color change in the deeper layers of the enamel. So, in order to test this, make sure that you remove any old restorative material that there is and only then test for this, okay? This is what I was talking about, the trans illumination. Basically, you have a fiber optic trans illumination probe. You place it at different points on the surface of the crown or the root. Because the refractive index of the crack differs from that of the peripheral tissue, there is a back reflection of the light reaching the crack, resulting in the fracture line being distinctly displayed, as you can see. We have many devices that are there, and one of them is Microlux, which is available to us in India for approximately rupees 38,000. I'm not sure of the exact rate, but you can look at it on Dental Cart. Okay. Now, dentists usually diagnose cracks by observing the peripheral crack lines of the fractured surface. However, the observed crack lines do not represent their size and shape. Experienced clinicians have suggested that the magnification used to assess the range of enamel cracks is approximately 14 to 18 times, and 16 times is actually the optimal magnification used for evaluating enamel cracks. So, coronal restoration removal, basically, you need to remove all these restorations in order to evaluate cracks. But look at this image. Look at the amalgam restorations in all of these, and they have ended up causing cracks right next to these restorations. And this is why the cracking in that area has caused development of the biofilm carrying all the microorganisms into deeper layers, and then causing caries in that area. It is impossible to visualize cracks on radiographic images. Only fractures, which is the next stage of cracking, and that too oriented in the radiographic axis, will be detectable. The most frequent radiographic features of the fracture appear to be a halo around the root, which is a periapical and periradicular radiolucency combined on one or both sides of the root. Now let's look at some therapeutic strategies. So our basic goal is going to be to limit the bacterial infiltration, right? Biologically, pulp dentine and periodontal biocompatibility is absolutely necessary. The pulp dentine biocompatibility aims at protecting the complex and ensuring sealing using adhesive systems to avoid basically bacterial contamination, percolation, and pulp irritation. So, firstly, it involves removing the line of cracks to prevent further bacterial penetration. Nevertheless, it may be practically impossible and also damaging to attempt to chase cracks extending to the pulp or along the root surface. So, what has been suggested by the biomimetic team is that we are going to remove the cracks and clean them completely only in the peripheral seal zone. Peripheral seal zone is nothing but 2 to 3 millimeters inside of the DJ, which is this area. I'm not sure if you can see clearly, but almost up to this area. Because beyond that, you have the chamber deep below, and removing cracks deep in that area means risking pulpal exposure. So we're going to remove only till that area. Then we are going to do immediate dentine sealing. And eventually we'll do some sort of composite buildup or cervical margin relocation to finish the treatment of the crack. The hybrid layer that we create basically inhibits the propagation of the crack due to its capacity for deformation and absorption of stresses such as the DJ. The composite resin that we put after that as a build-up material also has a shock absorption effect by increasing the cusp stiffness and redistributing the occlusal loads away from the crack towards the axial walls and along the long axis of the tooth. In addition, if you have optimal bonding of these restoration, it improves the strength of the ceramic and the prepared tissue, and it helps to stabilize these weakened cusps. Okay, let's discuss it all with a case. Okay, so now in this particular case, you have cracks in enamel, which I'm going to leave completely. This patient came to me with sensitivity with related to this tooth. We did a cold test to understand if the status of the pulp was in a reversible or an irreversible state. Okay. TOP was negative, which means she did not have as such any bite issues or any periapical involvement. There was a filling over here. This case was transferred to me while another colleague was removing the restoration, and then they saw that the patient had this crack and they didn't know to handle it. So I was referred midway during treatment, and that is why this is my pre op. So I could see a vertical crack, and you can see these cracks that are going into dentine, and these need to be treated. We're not going to be removing these cracks in enamel because they're harmless, as we have seen due to the biology of the enamel. But the cracks in dentine need to be removed, and this is how you remove them. So crack dissection in the peripheral seal zone has to be done, and crack removed till 5 millimeters from the cusp tip, because this is the limit of your end point. You're not going to go deeper than that. After that, I placed some fibers in the crack zone in order to help stop the propagation of those cracks. These fibers will basically stop and help in removing the or inhibiting the growth of this crack. And after which I continue to build it up in a normal way as a composite filling material only. So this is one of the ways to handle a cracked tooth. Okay. So as we all know, we need to limit the crack propagation, right? One of the goals of the treatment is to immobilize the crack fragments that move during loading, and that can be achieved by splinting and covering the cusps. Now, splinting doesn't mean always that you have to splint with the help of wires. It can be done with the help of fibers. It can be done cover the cusp with ceramic or some sort of an onlay. Basically do some sort of cuspal coverage that reduces movement that is happening due to the crack. The reduction and the covering of cusp allows for reduction of and therefore fewer symptoms. It also distributes the occlusal load evenly over the entire tooth, which minimizes the stress. You also get some sort of protection against protection of cusp from stresses towards the outside, and of course it increases the fracture toughness of the tooth to the level of an let's discuss another case while we are discussing how to treat these cracked teeth. So another see that these cracks right next to the amalgam in the mesiolingual cusp of this lower left mandibular molar hollow from inside, because of the cracks that have formed and they have carried carious tissue underneath. I wanted to what is going on just below the cracked tooth. You can see the difference. This is an amalgam filling, and I'm doing both the 6 and 7. Look at how when I remove 7, just the tooth, the dentine is so clean. If done properly, it was very clean. But look at what is going on below the amalgam restoration as a mesolingual cusp. So it needed to be cracked. As you can capped. So as you can see, the mesolingual part, the mesial DJ, I've removed the crack completely in the peripheral seal zone. Even in this area, I have removed the crack completely, and the mesolingual cusp needed to be capped. Again, I proceeded with immediate dentinal sealing and a bit of composite build-up to hold the entire thing together, to build that hybrid layer, inhibit crack propagation. And it was scanned and milled with the help of CEREC software. And then a ceramic onlay was finally bonded on to replace the cusp that we lost. Okay, and this is the final post-op of the same case. So basically, if you have a cracked tooth, you need to first check if it can be saved with just restoration or it needs some sort of endodontic treatment, which is when you will do the cold test to figure out the status of the pulp, whether it's in reversible state or an irreversible state. If it's in a reversible state, remove the restoration and cracks. You do a sedative lining, which is nothing but IDS. We no longer do these temporary restorations and stainless steel band because temporary restorations don't hold the tooth together, and in that period, the tooth is very sensitive, and there's going to be a lot of flexing due to the open cusp. So we have to, whatever we do, we have to make sure that if we're removing the cracks and the restorations, that we do some sort of composite buildup on the same day. Okay, so all this temporary restoration and stainless steel band we will not do. We will not reassess after days or weeks. We will be doing immediate dentinal sealing. And what you can do is defer for a ceramic restoration if you are unsure about the status of the pulp, because later on it might need endodontic treatment. So just do a composite and evaluate for maybe 2 to 3 weeks, after which if the patient does have any symptoms, they will come and tell you and you can do endodontic treatment. Mind you, consent is very important in such cases because cracked teeth can be very tricky to negotiate with and explain to the patient what's going on. Okay, so that is a tricky part. You have to explain and in very much detail that what is going to happen, because sometimes even we as doctors can't be sure of how the tooth is going to respond. So make sure that you tell all the possibilities to the patient before starting the case. The prognosis again is determined by the extent of the fracture. So in case you feel like the crack has progressed very deep into the tissue, it has gone beyond the pulp chamber and you're doing an endodontic treatment, these statistics help in deciding the prognosis and conveying the same to the patient as well. If the crack has propagated, just to the cervical dentine, then you have, after endodontic treatment, you might have the survivability of the tooth to up to 90 to 92% for up to 5 years. If the crack has extended onto the canal orifice but with no periodontal involvement, then you can have a survival of up to 82% for up to 5 years. But if you have radicular cracks with periodontal pocketing, then the survivability of such teeth is up to 74% for over 2 years. So this is something that you need to inform to the patient, because they will decide then whether they want to save the tooth or whether they want to go for extraction now itself. Because if you do some extensive treatment like root canal, cap, and then spend a lot of money, and the patient ends up cracking and splitting the tooth within the next 6 months, the patient is going to come and tell you, why was I not told of this option before? So if they wish to go ahead with an implant at this stage, now is the time to tell them, and it is their decision to make. So basically, to give you a very basic guidelines, when you have a crack, if you have it in enamel, it's a craze line, you don't need to do anything. If it's internal in the dentine, there are two types of cracks, which is oblique or vertical. If you have an oblique crack, is it good, or the rest of the tooth is bad? Depends on the amount of tooth structure remaining. You will decide what you want to cap it with, whether you want to do an onlay or an overlay. If the rest of the tooth looks really bad and if you have a vertical crack, you will be doing a full occlusal overlay because we need to cover all those cusps. Okay. Now, I want to tell you something about these oblique and these vertical cracks. So the clearer the fracture lines appear clinically, the more vertical the cracks are, and more likely that they are due to compressive stresses. So need to remember this. If you see a very clear fracture line, like the one I showed you in the few cases that we discussed just now, very, very clearly it was visible, right? Those are vertical cracks and they're due to compressive stresses. So this tends to ovalize the whole structure of the tooth. On the other hand, if you have a very shallow fracture line, they're barely appearing, then it means that it's an oblique crack, and more likely they are related to tensile stresses. And this is very dangerous because it tends to deflect the cusps outside of the occlusal parameter of the tooth. Now look at this tooth very carefully. You will see some cracks and probably you might not see others. If you look at the red lines, they are the vertical cracks due to compressive stresses, and the blue lines are actually the oblique cracks due to the tensile stresses. These oblique cracks are more dangerous, as I told you, because they tend to deflect the cusps outside of the occlusal table. And this is why I was telling that temporization does not work, because you need something to hold the cusps together. Okay. So just remember this. This is only to understand what kind of cracks you're dealing with, and in order to decide what kind of cuspal coverage are you going to offer to the tooth. Let's discuss another case now. Okay, so this patient came with this composite filling, and I advised him to, change this composite filling because I could see a crack here in the distal marginal ridge, and I could see some sort of discoloration just below the composite filling, and I felt like it needed to be changed. And mind you, on the X-ray, you can see that nothing as such is visible. But when I removed this composite restoration, I saw this huge, base that I think was used earlier, the zinc oxide base that people would give. And when I removed the entire thing, I could see there were just too many cracks. So as you can see, this most prominent crack is a vertical crack due to compressive stresses. It's a maxillary molar. It's going to have a lot of compressive stresses. But the fine cracks that you cannot see, these are the ones which are oblique in nature. So in this case, I felt like I was very deep, and in these two spots I felt like there was some exposure and I wanted to be careful, and I capped those areas with bioceramic material, that is biodentine, I think. After which so can you see how big this crack is? I took a different angle picture of a same crack, but it is going all the way, across the tooth. So mesodistal cracks are very dangerous. Then I did an immediate dentine sealing, and then I built up the entire tooth to keep it under observation, and it is doing fine. This next case is very interesting. This patient came to me with severe sensitivity with related to this tooth. And when I removed the small filling, I saw a mesodistal crack going all the way from one marginal ridge to other. So these cracks are very dangerous. When you have a proper mesodistal fracture like this, a crack like this, be very careful while you are attempting to treat these teeth, because you never know what you're going to find underneath. And that is exactly what I did. I sent the patient for a CBCT, and I saw that a fracture line extended all the way from the coronal area till the furcation, which means that it was just few, maybe I'm not sure how much time it had from a split tooth. So the patient, and everything was told to the patient, and the patient still wanted to go ahead and try to save the tooth. He was a heavy tobacco chewer, and all his teeth were cracked in the same way. And I told him, you might end up losing them due to the cracks and not the caries. But he still wanted to save this tooth. Okay, so we did the endodontic treatment for this tooth. I took consent and everything. The patient returned after about 6 months saying that this tooth was paining, and now the pain is due to the periodontal involvement, because as you can see, the crack has gone deeper and it has ended up splitting the entire tooth. The tooth was later extracted. So uh, in this situation, you have to be very careful, because when such patients come to you, they can tell you that your treatment ended up, making them lose their tooth. But if you explain to them very clearly what you're doing, and it's on you, and the consent is formed. This patient came back to me again, even though, so he knew that I had told him, and that is exactly what happened. So they were very prepared mentally to get the extraction done. Okay. Coming to prevention, so basically maintain good oral hygiene, avoid all these habits, eating betel nuts or tobacco chewing. Make sure you have frequent dental visits so that we can catch them early. Avoid clenching or grinding, or if there is one, seek some sort of solution, or come to the dentist so that they come there, we can give them some sort of occlusal guards or therapy, and of course have a proper diet. These are the things that we can tell to the patient in order to save their teeth from cracking. Concluding this, nevertheless, rebuilding and reinforcing the remaining structure of the cracked teeth often leads to some sort of clinical frustration, because mineralized dental tissue cannot heal by itself, and to date be remineralized or repaired. So it is very difficult, although a latest research in Japan has been claiming that they have been able to regrow human dental tissue, but that technology is still yet to come to us. So, changing the range and the direction of occlusal loads is actually often the best treatment option to prevent the extension of cracks, which could possibly lead to the loss of the tooth. So, in such cases, as you can see, all my cases, adhesive dentistry, even though not invasive, but at least it provides an opportunity to preserve as much sound cervical tissue as possible and avoid the further tooth preparation that would be required for other treatment options, for instance, a full crown. In most of my cases, as you can see, I managed with just a simple removing the crack in the peripheral seal zone, doing immediate dentinal sealing, composite core buildup, and then covering the cusps with an onlay or an overlay, So, ongoing investigations in the field of biomaterials, as well as future research into the biological repair processes, will without doubt, increase the therapeutic range available to treat and repair cracked teeth. But for now, this is all we have. The biomimetic way is all I can tell you as I was taught. So, treating cracked teeth is very challenging in daily practice, and I hope I have been able to solve some of those doubts that you had. uh, I'm only trying to save cracked teeth so that they don't, go and progress on to becoming a split tooth. This is one of my patients only. I had told them, to cover the cusps and go for some sort of coverage because I had done just immediate dentinal sealing and a composite buildup. They never came back to me, and then later came when they had cracked the tooth completely. So this is a very sad thing because we do so many things to save the tooth, and then the patient does not listen and wants to delay the most important procedures. So this is what happens when you have excessive deflection of cusps, especially a second molar, lower second molar. It can end up splitting the tooth. So today's presentation and webinar was mostly to prevent this next stage. I hope I've done my bit, and if you have any questions, I'm open to taking them.
Ma'am, there is one question in the chat box. Ma'am, how to do immediate dentinal sealing? What are the steps involved in IDS? What is delayed dentinal sealing?
Where is it? Okay. So immediate dentinal sealing is nothing but a concept which was talked about like many years ago, but formally written in a paper by Dr. Pascal Manier. Uh, he talks about is that whenever you cut dentine, either superficial or deep dentine, make sure you're sealing the dentinal tubules immediately. That is the main cause of sensitivity or the post-op sensitivity that happens later, right? So immediate dentinal sealing is the concept that I propose for all your cases, whatever you do, whether you're doing veneer preps, whether you're doing crown preps or onlay preps, any sort of prep where you are involving the dentine of a vital tooth. You're going to seal the dentine with nothing but your bonding agent that you have. Now, the ideal bonding agent to use is your gold standard bonding agents, which are two. One is your fourth generation OptiBond FL, which follows the total edge concept. It has a two bottle system, which has primer and an adhesive. And the second one is your sixth generation bonding agent, which is your Clearfill SE bond, which is again primer and adhesive. Okay. So what happens with OptiBond FL is that it's a highly filled adhesive agent. So if you apply it only in one layer, because it is so filled, it gives you that protection immediately with the help of the adhesive only. For Clearfill SE, the adhesive that you apply is not as filled and it requires a layer of build-up, which you can do with the help of a highly filled flowable material of around 0.5 to 1 millimeter. So that's the difference between these two systems, adhesive systems. And you can do IDS either just plain with adhesive or with the help of an adhesive plus a layer of flowable on top of it. Delayed dentinal sealing is when you do the same thing in a delayed manner, like when you do crown preps and you're doing on the day of cementation, you are doing you are applying bonding agent on the dentine, right? So that is not on the same day that you've cut the dentine, that is delayed dentinal sealing. Which materials are used for IDS? I've already explained. I've already told the materials. You can use any material for immediate dentine sealing. You just have to seal the dentine. Use any bonding agent. Any more questions? I'm open to taking.
Ma'am, there is one more question. Can we do IDS with 8th generation bonding agent?
You can do it with any bonding agent. You can do it. So, 8th generation bonding agents are your universal bonding agents. You don't have a two-step system. So, in that area, you'll not have like a primer and an adhesive. What you can do is apply the same thing twice, once as a primer and the second time as an adhesive, and then cure it the second time. If you have any further doubts, I'm open to connecting maybe on social media. If anybody wants to get in touch with me, they can do so. But I think for now, we have wrapped up almost all doubts. Right, Japleen?
Yes, ma'am. So I would like to end the session for you. Thank you so much, ma'am, for sharing your time, your knowledge with us today. Definitely, the management of a cracked tooth helps in important early recognition, proper diagnosis, and effective treatment strategies. On behalf of Finders of Dentinos, I'd like to extend my heartfelt gratitude to you for being with us today. And a big thank you to all the participants as well. Their enthusiasm made this session possible. We at Finders of Dentinos will continue to bring these knowledge-filled session for everyone here. So stay connected with us on Instagram as well as ma'am's Instagram that will forward in the group as well. Until next time, keep learning, keep smiling, and keep growing. Thank you so much, everyone. Thank you so much, ma'am.